National Assembly on the 7th of June 2023 at 10 o'clock. We are here to receive a presentation by the South African Academy of Family Physicians. They had written to the Portfolio Committee. I actually looked, it was about April last year, 2022, requesting an opportunity to come and present their position paper, which speaks to their understanding of the role of the family physician specialist and the family physician's placements within the health system. And we have been very busy. I'm very sorry that it had taken us a year to get to the point where we actually get to listen to the presentation from the South African Academy of Family Physicians. But with that having said, I want to also welcome Professor Russ and the other members of the SAAFP to this meeting of the Portfolio Committee on Health. Before we continue, I want to ask Ms. Majalamba to give us an indication of attendance. And thereafter, I will ask Mr. Johannes Gatla to give us an indication who has joined from the NDOH. Ms. Majalamba.
Good morning and thank you, Chair. Present is Dr. Jacobs, Ms. Taylor, Dr. Harvard, Dr. Nothnagel, Ms. Clark, Ms. Wilson, Dr. Tembekwa, and Dr. Tembekwai. I've received apologies from Ms. Sukers and Mr. Van Staden. Thank you, Chair.
Thank you very much. Mr. Joe Gatla, can you give us an indication who has joined from the department?
Good morning, Honorable Chairperson and Honorable members. Chairperson, Mr. Victor Kanyile, who is the Director on HR, will be joining the meeting on behalf of the department. He's been deployed by the Minister. Thank you very much, Chair.
Thank you very much. Will he be joining? You said he will join, so if you could maybe get into contact with him.
Yes, Chair, Honorable Chair, he will be joining. He's joining actually as we speak.
Thank you. All right, so members, just to remind us that this is a meeting, even though it's a virtual meeting, that is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons on the bar at the bottom of their screens, which has an option that allows a member to put up his or her hand, raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjections. So, honorable members, I will go straight to Professor Russ to give us an introduction of who the people are who would come with him, who have joined him on this presentation as the SAAFP, and we will go straight into the presentation from them thereafter. Have you been made a co-host yet, Professor Russ?
Good morning, Honorable Chair, and good morning to the honorable members. I have been made a co-host. Yes, thank you.
Thank you. Please introduce your members.
So I'll introduce myself first. I am Prof. Taslim Ras. I'm from the University of Cape Town. I'm also a director of the South African Academy of Family Physicians. We have invited two of our other co-directors, Professor Andrew Ross, who's not yet on the call. He's from the University of KwaZulu-Natal, and Dr. Jenny Nash, who is working in the Eastern Cape with Walter Sisulu University. And I also note that Professor Klaus van Pressenton has joined the meeting. He's the head of family medicine at the University of Cape Town as well.
Thank you very much. Let me welcome all of you. I know some of you personally, so I'm looking forward to what you will be presenting this morning. And I'm hoping that Prof. Ross will still join. Mr. Kanyele, I'm sure, would have joined by now. I just want to make sure that the department is present. Mr. Gatla? Give me an indication. I'm looking on the system.
I realize he's not in yet, Chair. Let me check him. Let me call him and check, but he's not on the platform as yet. Thank you, Chair.
Thank you. So we will continue while we're hoping that the two other people mentioned will join. So I'm handing back to you, Professor Russ. You're very welcome to do your presentation. How it works here is you will do a presentation. We normally allocate about 3 hours. It'll probably be a bit shorter today because we're going to listen to you. And then I give an opportunity to the members of the portfolio committee to raise any points of clarity or questions or any concerns they might have, or even if any input that they really want to make, so that you then allowed an opportunity to respond to those. And then we close our meeting. Thank you. Please proceed.
Thank you, Chair. Can you please give an indication if you're seeing my screen?
I do. Maybe you should just go to slideshow.
Yeah. Is that visible?
There we go. Thank you.
Wonderful. Excellent. So, good morning, everybody. Good morning, Honorable Chair, honorable members of the Portfolio Committee, and members of the Department of Health and colleagues from other universities. On behalf of the South African Academy of Family Physicians, I just need to thank you for the opportunity to present this position paper on the contribution of family physicians to district health services in South Africa. This was a position paper which was developed as a consensus document across all of the participating universities in South Africa, and which is the second iteration of this document, which reviews and projects the role of, and the contribution of this cohort of medical specialists to our health system. I have already introduced my colleagues who are joining me today. I just want to spend 30 seconds talking about the South African Academy of Family Physicians, which is a representative organization of family physicians in South Africa. Not only do we represent family physicians' interests from a health service perspective, but we also are quite actively involved in developing curriculum for training family physicians. And we're also very active in mentoring young family physicians who have just graduated. We are predominantly focused on academic family medicine and on family physicians who are working within the state sector. And we are at the moment engaging with those family physicians who have not found employment in the state sector and have struck it out into the private sector in South Africa. So just to give you a sense of who we are representing and who I'm speaking on behalf of. So the purpose of this briefing today is fourfold. Firstly, I'd like to explain what family physicians are doing on a day-to-day basis in strengthening district health services across the country, in all provinces. Maybe I'm going to touch on some misunderstanding in the policy on the role of family physicians, and particularly in relation to the human resources for health policy. maybe I'm going to talk a little bit about the contribution of family physicians to national health insurance, not a lot of it, but we're going to touch on it. And then some recommendations to the national provincial departments of health on the future deployment of family physicians. And importantly, I'd like to touch on the training pipeline, knowing that family physicians need to go through a fairly rigorous process of training before they can be accredited as family medicine specialists. So the context is that as of 2019, which is the last time we sat down and collated information about what the national footprint looks like, we had a total of 1,247 family physicians on the health professions on the HPCSA specialist registry. Now, why this is important is because the HPCSA represents the only official registry that collates those medical doctors who have met the criteria to be granted specialist status. Now, the criteria to be granted specialist status follows a 4-year training program at an accredited facility, and the HPCSA is quite active in accrediting those facilities. This training program has been around since 2007 officially, and so it's one of the youngest medical specialty training programs in South Africa. And we have relatively small numbers of colleagues who have met the criteria for registration. I must add that those people who had the requisite skills and qualifications prior to 2007 were granted a special dispensation to be registered. However, that window of opportunity has closed since the specialist registry has been made the formal manner of training for family physicians. So we'll see that you'll see on this graphic that we speak of medical practitioners and medical specialists. And it's important to note that the medical specialists are those who had some kind of qualification to be able to enter onto the medical specialty. The minimum qualification for that typically is a master's degree within the specialty. This becomes a very, very important slide for us to think about, because it shows the distribution of family physicians across the provinces. And this is always an important discussion for us in South Africa when we think about equitable distribution of resources. The topmost category is the area with the least family physicians per 10,000 population as of 2019. That hasn't changed substantively, and I'll explain why in a moment. Followed by the Eastern Cape, the Northwest, and at the bottom, you'll see that the Northern Cape, most likely because of its fairly small total population, and the Western Cape has the highest concentration of family physicians in the country. Now, right in the middle, you'll see the category total. So our total family physician per 10,000 population in South Africa is 0.16 per 10,000 population. Now, that's a figure that we can think about and very difficult to benchmark. And the reason it's difficult to benchmark, because typically we'd be thinking about benchmarking against norms which are maybe international in this instance. And when we have countries with very varying health systems, it's difficult to start comparing. So for example, the average in Brazil is 0.2 family physician per 10,000 population. But Brazil has a fairly different health system to ours. In China, 1.2 family physicians to 10,000. And once again, China has its own unique contexts. And even higher in the UK with the NHS. I think what's important for us to note is the fairly large disparity within South Africa, between these various provinces. And I want us to hold that in mind, particularly when I get later on to the ask that we are putting on the table as an organization. When we look at the distribution of the qualified family physicians in South Africa, the vast majority of them are sitting in the private sector. Now, speaking to colleagues who are sitting in the private sector, this is not by design. It's almost by default. And the reason being that the state sector at the moment just has not produced sufficient posts to incorporate those people that have recently graduated. So at any given point in time, we would have a fairly significant number of graduates who are not able to enter into the state sector as family physician consultants, simply because there haven't been enough posts created. So when you see that 29% of family physicians that have been produced in the country are working in the state sector, and we recognize that our total distribution of family physicians per population is about 0.16. When we multiply that by that 29%, we come to an even more shocking figure of 0.005 family physicians per 10,000 population who are needing the state's resources. So we know that we're sitting in a country where approximately 25% of our population are medically insured, and the balance of the population is needing these resources, the state resources. And so we're sitting with a situation where we have very low concentrations of an important medical specialty, and I'll unpack how important that medical specialty is to our health system in a moment. And we're sitting with a concentration of 0.05 family physicians for every 10,000 people in our population who are using the state sector resources. And that is a very worrying, difficult stat to work with when you consider the multiple and complex diseases that our patients within the district health system experience. So what's been the contribution of family physicians? And there's actually been, in the last 10 years or so, a fair amount of research looking at what the family physicians have contributed within the district health system. Excuse me. I say a fair amount, Chair, and I use that word fair very specifically because there hasn't been a lot of research into what family physicians have done. But the research that has happened has been of a good quality. So the contribution of family physicians happens within the district health system. The district health system, the typical facilities that we see in the district health system are your smaller district hospitals, as well as your primary healthcare facilities. And it extends beyond the primary healthcare facilities into community-based services. These district hospitals within the urban setting are typically your small hospitals with between 30 to 60 beds, and they don't have other specialists besides family physicians working in them. And the district hospitals also include our smaller rural hospitals, providing care to outlying communities. The family physicians within the context of primary health care, they deliver clinical care, but very importantly, they play a mentoring, supervisory, and governance role in ensuring that the primary healthcare services are of an adequate standard. And similarly, in the district hospital, where patients are treated who don't necessarily need to be seen in the tertiary or the secondary hospitals, the family physicians provides direct clinical care, but also in many ways, and I'll be speaking to that in a moment, an oversight and a supervisory role within these district hospitals. When we considered the overall contribution of family physicians to the district health system and to the staff working within the district health system, we have three overarching categories. The first category relates to direct clinical care. And so the family physician would work directly with patients as a clinician, but they would also be a consultant to other clinicians within the district health system. And when I say other clinicians, Here, I mean other doctors who are called medical officers who don't have a specialty training, as well as nurse practitioners who are dealing with patients, as well as physiotherapists, sometimes pharmacists, our radiographers, our occupational therapists, our psychologists. So the family physician then acts as a consultant to all of these other interdisciplinary colleagues. The second big category is that of capacity builder and clinical trainer. And we recognize that this is an ongoing contribution to the improvement trajectory that our district health services are needing to undergo on a continuous basis. And in some areas, we'll find that that there's been more rapid progress than in others. Oftentimes, that is related to the contextual factors that influence the type of work that the family physician needs to do. And so sometimes we'll find that the one role, for example, the role of clinician, is so badly needed that the family physician doesn't have the capacity to play the role of capacity builder because he or she is too overloaded with clinical workload. The third category, which is very, very important, and we'll talk about this in a little bit more detail, is that of a leader of clinical governance. Now, when we understand clinical governance, we think about what are the quality indicators of clinical care. What are the standards that we aspire to within our clinical care? How do we monitor those standards? How do we maintain those standards? And how do we also ensure that there's constant quality improvement in the clinical care? So clinical governance becomes an important, broad-ranging portfolio that the family physician also holds. So how do we prepare the family physician to be able to take on these multiple varied tasks? Family medicine is a postgraduate training program. To get into the program, you need to be a qualified medical doctor who has completed the 2-year internship and the 1-year community service. It's a competitive process to get into the training program. Once in the training program, the student, which we call the registrar, will rotate through 10 clinical domains over a period of 4 years. The clinical domains are outlined there. Those clinical domains were decided once we sat down and considered what is the burden of disease within the district health system, and how do we then describe or design a training program which speaks directly to the district level burden of disease. It's not a curriculum which was floated in from somewhere else and imposed on the district health system. We are very proud of the fact that our curriculum grew out of an acute understanding of what is needed within the district health services and at community level. And so as a clinician and consultant, someone who's gone through these 4 years, and they are very rigorous years of training, has enhanced clinical skills to work across the entirety of the district health platform as a clinician, and in particular has been accredited to deal with a certain level of complexity and complication within patients. And we can talk to that if you want. I can unpack that concept a little bit later if you'd like me to. When we have a cadre of staff who is well trained to work across the entirety of the district health platform, we enhance the comprehensiveness of services. And so where there may have been skills gaps, and I think back to a colleague of mine from Stellenbosch University who in the early 2000s went around to district hospitals and measured the skills. She did a skills audit on the doctors working there and found that there were pretty large skills gaps within our district health services. Now, those skills gap means that now the service cannot be offered to that particular patient close to where they live, and that patient then needs to be referred onwards to a higher level of care. And what family physicians have done in their clinical and consultancy roles is to fill many of those skills gaps. And in addition, we've been able to enhance the package of care and the service delivery in district health services to incorporate in many areas palliative care, which was an unrecognized need within all our communities. There's not a single community within South Africa, within Africa, that does not need properly trained palliative services. And we all understand the importance, the strategic importance of looking at health promotion and disease prevention as an arm of primary healthcare services. Prior to the introduction of family physicians, there were no specially trained consultants who were available to clinicians as consultants within the district health services. If you worked as a medical doctor or a nurse within the health services, you relied on your peers who had varying levels of experience and expertise to help you with difficult cases. With the introduction of family physicians, we now have a comprehensively trained, accredited by the HPCSA, professional at master's level who is able to act as a direct consultant to those nurses and other healthcare professionals who are working on the district health services. So since we started introducing our first family physicians into the district health service, and I think the first cohort qualified around 2011, and prior to that, those of us with the training before the formal training, we were also quite active in the district. So around the mid-2000s, when we started being introduced as a profession into the state sector, for the first time ever, there was a home-based, when I say home-based, I mean district-level based consultant who was active within health facilities to provide day-to-day guidance and consultancy services, which had an immediate impact on the quality of care. And when you're able to offer a higher quality of care, which is more comprehensive, it reduces the need to refer. So in areas where family physicians are fully integrated into the clinical teams, there is well-documented evidence that the rate of referral upstream to our secondary and tertiary hospitals is much less. And the main reason is because those patients, number one, they're caught early in the disease progression, but also you now have a person well-trained who's able to manage a certain level of complexity which would previously have been referred to a higher level of care. And then very, very importantly, patient-centered care has become our mantra, if you want to call it that. It's become the way in which we start engaging. And it's not only in relation to patients. We prefer the term person-centered care because it's also in relation to our colleagues, our juniors, our nurses, etc. So if we start thinking about how do we change the culture of our health facilities to be more person-centered, both in terms of staff and in terms of the communities with which we are working, then family physicians offer that opportunity for role modeling within the system. The second big domain is that of capacity builder and clinical trainer. And here, before I get into the specifics, I must say that part of the 4-year training is not only about clinical training. There is a strong component of the training program which focuses on our graduates being able to teach, being able to mentor, being able to have difficult conversations, being able to build teams and nurture a learning environment. So in the first instance, the family physician then provides support and supervision to the team. So it's not only coming in as a consultant. That person also accepts that they have a right, a duty to provide leadership in terms of developing the clinical service package. Oftentimes, family physicians coordinate training, in-service training for staff, ensuring that staff are capacitated in-house to deal with the needs of the community that they are serving. And the family physician, because of the comprehensive training, is able to touch on any aspect. And I must stress this. This is not an exaggeration. The family physician who has graduated from one of our training programs is able to offer training to a clinician in any part of the district health system. And once again, I can unpack if you'd like me to in the question and answer session. Where the family physician is attached to a university, which is in many instances, almost all our institutions, our health facilities are now attached to some kind of a training platform. The family physician also teaches and trains medical interns, medical students at the undergraduate level, and the registrars who, as I said earlier, are people that are busy specializing within the discipline. Now, when you have someone as part of your team that you can pick up the phone with, who's in your WhatsApp group, who is going to come and check up on you 2 or 3 times a day, your ability as a young clinician or as a young clinical team, your sense of self-efficacy and your confidence in delivering a good quality of care to your community is enhanced. And we found this over and over again in research that we've done in many different areas. When I say areas, I mean geographic areas. Creating a learning environment within the clinical space is fundamentally important to ongoing clinical improvement. To ongoing quality improvement. When we think about delivering clinical services, it's not only about seeing and treating the patient in front of you. It's also about creating some kind of an environment in which there is a willingness to constantly improve. Our population is owed this by us as professionals. And so the family physician enters into that working environment with an express intent of being part of a quality improvement process, and in so doing contributes to the development of a learning environment. When, we've got this great ambition that every clinical space becomes a learning space. Clinical spaces should never ever become spaces where learning is not fully incorporated. And the reasons are quite obvious. I'll state there's always going to be technological and knowledge advancements within the practice of health systems and healthcare. And so every clinical space needs to be engaged with the process of ongoing improvement from that perspective. Once clinical spaces, and unfortunately, what we inherited when we started this process almost 2 decades ago were clinical spaces which had not changed in many, many years. And as a result, the services they were offering were stuck in old ways of doing things, which were not necessarily the best ways of doing them. What the learning environment also does, it has a direct impact on the retention of staff. So when a young doctor, young nurse, young other health professional comes into a team and they are able to learn, they are less likely to pack up their bags and leave. And yeah, I speak particularly to underserved areas, in our rural communities, in our underserved peri-urban communities, in our communities that are largely informal. When we have good quality family physicians who are leading those teams, we found across the country that there's an increased retention of staff. Now, retention of staff within health services is vitally important because the thing that connects the health system at the community level with that community, or the thing that connects the individual health professional with the patient, is continuity of care. When we stay long enough in a particular place and we're able to build strong relationships with patients and with communities, we are able to deliver much, much better health services than if we are moving every 6 months and people are changing all the time. The third big area is an area of clinical, is as a leader of clinical governance. And as I said earlier, the way we defined clinical governance is the setting of standards of quality of care, the monitoring of those standards, and then intervening in ways that are constantly improving on the quality of care. And this includes risk management. So being aware of the adverse events, being aware of when things go wrong, engage with communities and patients and families when things have gone, and then putting things in place to mitigate that the factors which have impacted that adverse event are addressed virtually immediately. If you don't have the person in the facility who has that level of thinking, then those factors tend to fester and they go on and on and on. And I suspect this is one of the reasons we have such high medical legal risk in many of our facilities, that we don't have this thinking around risk management. And so there are a number of clinical governance activities by which family physicians engage in clinical governance activities. For example, a family physician would go through, say, junior doctor saw a patient this morning. I would go and fetch the folder and I would go look at the folder to see how good was your care. When something goes wrong on a monthly basis, we have morbidity and mortality meetings. When there are difficult decisions to be made about providing a service or not providing or not being able to provide a particular service from an ethical perspective, the family physician steps in and leads that conversation. When there are actual risk events that occur, family physician steps in and leads the conversation, both with all of the relevant stakeholders. Patient safety in these conversations are always at the heart of what we focus on. In the last few years, family physicians have been very proactive in implementing community-oriented primary care. And this is potentially one of the exciting areas where family physicians can really make a very significant contribution. And this is a contribution outside of the health facilities. So it's beyond the walls of the clinic. When we speak of community-oriented primary care, we're speaking about engaging with the communities where they live. And frequently, in our training programs, we insist that our trainees, as medical doctors, join with community-based organizations in delivering home-based care. And the reason we do this is because we know that one day, when they are in this leadership role, they need to have an acute appreciation for what happens in the homes of patients, particularly in the homes of patients in underserved and poor communities. Clinical governance has a systems approach to looking at our pathways of care. And so family physicians have adopted this role of monitoring and assisting care across different levels. So for example, if I see a patient in a rural clinic on the West Coast, say in Langebaan, and I decide, well, this patient needs to be referred to Cape Town because there's some kind of medical complexity that we can't manage in Langebaan. As the family physician, I then ensure that the patient has access. I make sure that and I then coordinate that process of care across the different levels of care. I'll pick up the phone, I'll have regular conversations with a consultant sitting at Somerset Hospital. If that person gets referred to Groote Schuur, I will pick up the phone and speak with the person. And then in anticipation of that patient's discharge back to the community from which they come, my team and I will be ready to receive them. So you'll see that the family physician then assumes this responsibility across the entire spectrum of patient care. I'm not the treating physician at the tertiary hospital, but I certainly remain an interested party from a patient-centered perspective. And because I'm a leader in my community in Langebaan, I'm able to prepare my clinical team to receive that patient. I'm able to engage with the family to say, listen, we will assist you. I'm able to engage with the community-based services to say, what do we need to put in place to ensure that this person receives care at home? While we are not corporate governors, I think the distinction must be quite clear. We can influence corporate governance at the substructure level as well at facility level. Family physicians have accepted the role of appraising medical officers' performance, and that speaks directly to quality of care as well. And then, because we are generalists, we think in terms of systems. The person who decides that they want to become a family physician is not necessarily someone who only wants to work within a very narrow part of clinical medicine. We become family physicians because we enjoy this broad spectrum. And it goes even beyond the broad spectrum. It goes beyond medicine. We become systems thinkers. And the more we engage within the district health system, the more we're finding that we spend a little bit less time seeing patients and a lot more time working on systems and thinking about ways to innovate, particularly around areas of resource constraint, and finding ways to innovate our service configurations in ways that don't necessarily need more resources. A family physician in that instance becomes a very important partner in the service design process. So I just want to spend a little bit of maybe 2 or 3 minutes talking about the evidence that we built over the years. Now, these are just 2 graphics. There's much more. On the left, you'll see in figure 1, the impact of family physicians on a scale from 0 to 4 within each of those domains. This data was collected from people working, from managers, from other clinicians working within the district health services. And it was found that there was a very open appreciation and acceptance, almost a celebration if you look at how high the scores are. If 4 is your maximal score, most of those domains scored well above 3, or the contribution that the family physician had made. Now remember that this research, if you look at the bottom, was published in 2018. The research was done around 2013, 14, and 15. And we're now 10 years, almost 10 years down the line. And what that means is that we actually have potential for greater impact because we have a few more people on the ground. This research was done when there were literally a handful of family physicians within the district health system. Figure 2 is also very interesting. Figure 2 is very interesting because it compared the perceived impact of family physicians who had gone through the 4-year training versus medical officers who are doctors, but who had not gone through the 4-year training. And once again, participants, and this was broad study across the breadth of South Africa, participants were almost unanimous in saying that the contribution of the family physician in each of those domains noted there was very significantly more than that of a medical officer. The evidence is quite strong. It's not 50-50, it's not borderline. It's pretty strong to say that this person, this family physician, is able to make a real difference in the district health system. So we now know that the number of family physicians are directly linked to more cost-effective health systems. So when you have a family physician in a health system, quality of that ecosystem improves. And that's seen by a reduced number of referrals to higher levels of care. And when I say reduced, it's significantly reduced. A reduced number of repeat visits. So instead of someone coming to the clinic today and being seen very superficially, and then coming back next week with a problem, and the following week with the same problem, and you have this revolving door, we've been able, in many instances, not eliminate, fortunately, we don't have capacity in terms of numbers to eliminate that revolving door phenomenon, but we have been able to significantly reduce the number of repeat visits. There is a more rational use of resources. So we don't have junior colleagues coming and just prescribing medication ad hoc. There's been a strong drive towards rationalizing the use of medications, and family physicians have been at the forefront of this process, particularly in the district health system. And in addition to that, the rational use of laboratory services means that we've been able to cut down quite dramatically on the pharmaceutical and laboratory costs, not by cutting down on the usage or access to these services, but by improving the efficiency of decision-making at the point of care. And the long-term benefit, I think, which we are starting to see, is that medical legal risk is going down. Now, it might be too early to say that we've seen a significant impact on costs, but certainly when one starts to engage with the reasons for medical legal risk, one, and probably one of the biggest reasons, if you read the literature around medical legal risk, is communication and relationships. And one of the main drivers of the family medicine training program is that we focus very strongly on our graduates being able to communicate in difficult situations, and to be able to find ways of building relationships even in the most adverse of circumstances. So what are the implications for the national health insurance from a family medicine perspective? I think when we speak about quality of care, importantly, when we speak about patient safety, and when we think about what is going to be the district health system package of care, family physicians have a very, very significant role to play in all three of those. At the moment, Human Resource for Health Policy speaks about family physicians as part of the district clinical specialist team, but doesn't speak to our role within health facilities and within community-based services. And the role that I'm speaking about in the preceding slides is not a thumbs up. This is the work that family physicians are actually doing on a day-to-day basis. If you took a drive out to any of your district hospitals right now and engage with a family physician, that's the work that they are doing. We believe that the contracting units, CUPs, should each have at least one family physician attached to them. That remuneration for family physicians should be at the specialist level. We have that at the moment. But even within NHI, family physicians cannot be remunerated at a level which is not equivalent to other specialists. And the reason we've introduced this is because within the private health sector, within the private funding schemes, family physicians are not being remunerated at the same level as our other specialist colleagues. And then finally, that remuneration should incentivize medical officers who are doctors without postgraduate trainings and general practitioners to upskill themselves in response to the needs of the communities they are serving. So what are we asking for? Where we'd like to go is that we would like to see one family physician at every district hospital. Now that's a minimum. If I speak to colleagues who are working currently at district hospitals, one family physician is very stretched at the district hospital. 2 is better. 3 is even better. But at the moment, we're saying, being realistic, we're saying the midterm goal is that one family physician at every district hospital, community health center, and where there are no community health centers, at least one family physician at the sub-district office. At the moment, that would mean that we would need 680 family physicians in the public sector. We don't have 680 family physicians currently in the public sector. So we have our district health services, which are currently serviced by about 280 family physicians, which means that there's a gap of 400 family physicians. Now, if you look at the first bullet point, we're not asking, that's not a tall ask. That is saying, you know, if we want to run a well-run professional service at district level, this is the least that we need to have in place. And we have a fairly large gap if we are going to fill that need. Related to that is this reality. And that's the current supply of family physicians into the state sector, which is the domain of the universities. But the entry into the universities is limited by funding that we get from provincial departments of health. for registrar posts. So currently we have about 50 new registrars entering into the program. We have just over 50% throughput rate across the country, and varies from province to province, but kind of if we average it out, we have about just over 50, say 52% throughput rate. So about for every 50 new registrars coming in, we have 27 family physicians graduating. And of those 27, only 11 of them will remain in the public sector, not by choice, but because of unavailability of posts. Just to speak to the unavailability of posts, I have yet to hear about a family physician post which has stood vacant. You might find other cadres of posts which are standing vacant, but family physician posts are filled like lightning. If we are to fill that gap of 400 family physicians over the next 10 years, we'd have to look at 150 new registrars entry. The universities would have the work cut out to improve their throughput from 50% to about 67%, which means that we'll be able to produce about 100 new family physicians per year. And I think that is a process that the universities have already started engaging each other with via a process of peer review. What that would mean is that if 40% of those new graduates are taken up into the state sector, we'd have 40 new physicians entering into the public sector per year, which would mean we'd be able to close that gap within 10 years. So in summary, what we're asking is a consideration for a 3 times increase in the number of registrar posts across the 9 programs, that for the next period, 40 new family physician posts are created. And as I said earlier, if we created 40 new family physician posts tomorrow in the country, we would probably be able to fill them with qualified people. And importantly, we have to look at issues of equity across different provinces. So some provinces may need more posts than others. And so in conclusion, I just want to say that we are working hard from a university and an academic perspective to ensure that we are able to improve on our efficiency within our training programs. The family physicians who are working already on the clinical platforms are working exceedingly hard to ensure that they are constantly improving on the quality of the clinical offering. But we do need support from decision makers to enhance our inputs, to enhance our throughputs, which is our job, and then effectively to have an impact on the services that we want to offer to our populations. Thank you, Honorable Chair. For those that might contact me or Professor Barnes, the President of the African Academy of Family Physicians, our emails are available. I thank you for this opportunity, and we are available to answer any questions.
Thank you very much, Professor Russ, for this presentation. Is there anyone else from your team who has joined who wants to say anything? An opportunity for them.
I see Professor Ross has joined us.
Hi, morning, everybody. Thank you, Taslim, for your presentation. Yeah, I think we really wanted the opportunity to present the vision for family medicine and the role which we feel we can play in service delivery at a district level, and the role we can play in the implementation of the National Health Initiative. We wanted people to really read our position paper and then have an opportunity to engage with us around what it would mean to implement kind of having family physicians much more widely employed within the public sector. So thanks for making time. Thanks for engaging with us.
Thank you very much. Anyone else?
Good morning, sir. It's Dr. Nash. I'm Jenny Nash. I'm a family physician from the Eastern Cape.
Yes, Dr. Nash.
Thanks very much for the opportunity and for the presentation. Yeah, just to say that as a family physician in the Eastern Cape, sometimes people think that family physicians are too expensive, and I work in some of the former Transkei and Ciskei areas. And it's so important to be able to ensure quality of care, and especially some of the rural provinces where there are high rates of litigation, and patients are in very rural areas, and you need perspective to ensure that there's community-oriented primary care and patients have equal access to specialist services. And I think it's really important that we ensure that that many of the rural communities who perhaps haven't had that before are offered that. And district hospitals provide a much, I want to use the word, cheaper level of care than a tertiary hospital. And so if you're able to refer a patient to a district hospital and have family physicians working in the district, the patient's able to access that care without having to be referred. And in many of the rural areas, patients have to travel on dirt roads. We have problems with ambulances, and it just makes services much more accessible to communities. And I think what was also came up in the presentation is a family physician doesn't just have an interest in curative medicine. They have an interest in community members and the life course of a family. And so family physicians are able to support community health workers and ensure that patients are supported, well, people are supported in their communities. And then finally, we have lots of junior staff. We have lots of community service medical officers and even interns now rotating through our district hospitals. And it's important for them to receive mentorship. And many of them are receiving skills from tertiary hospitals, but when they go to a district hospital, they're either too nervous or to practice those skills, or they need mentoring. And by having family physicians there, those skills are able to be honed. And also some of the clinical governance issues, the professionalism, listening to people who have had a bad experience, and that ensures that they don't drop out of clinical medicine through perhaps a traumatic experience or a difficulty working in a team, because these teams are small. And so we're able to encourage teamwork and ensure that, as was mentioned in the presentation, these junior doctors are able to be retained in the service. And students also gain a good perspective across the health system. So we're trying to ensure that our students don't just get the view of tertiary curative medicine. And by students rotating in community health centers and district hospitals, they're able to interact with community services and see the whole scope of services. And there again, it ensures that we don't just produce doctors who are interested in curative medicine, but they understand palliative care, they understand preventative medicine. Thank you, sir.
Thanks, Dr. Nash.
Thank you very much. Prof. Morgan Naidu, see your hand raised.
Thank you for giving me the opportunity. Thank you, Honorable Chair. Yes, I just wanted to reiterate that, trying to manage patients at the lowest possible level of care is probably the most cost-effective method of using the limited budget we have in the public sector. And in order to do that, you don't put the least qualified people there. You should actually be putting the most qualified to strengthen some of those areas that Taslim has already covered, like clinical governance and leadership, because we always bemoan the fact that we don't have adequate leadership in health. And family physicians, through their training, are exposed to leadership training. And my experience with looking at the district clinical specialist teams as well is that often, even within those teams, the family physicians tend to take the leadership role in actually leading the team that's based at the district office. So they've already proved their ability to lead. And I mean, we've recently published a few studies which show that if you look at two common conditions like hypertension and diabetes, which is going to be the scourge of the next pandemic that we're going to be facing in the country, we have poor numbers. I mean, when we did an audit, we found only 40% of patients were controlled with regards to their blood pressure, and only 28% of diabetic patients actually had their target levels of HbA1cs. Now, the impact of having these chronic conditions poorly controlled is that these patients will then at some stage get complications like chronic kidney disease and require tertiary level care. And you know that many patients get excluded from the renal program because you just don't have the resources to offer renal dialysis or renal transplantation for this large number of patients. So the logical thing to do is to obviously improve their management at the lower level of care. So, I mean, the HPCSA has seen the need to increase the internship training in family medicine because they realize the importance of family medicine. But at the same time, you need adequate supervisors. So part of the problem with the internship program is that where there is a family physician, they've been very good feedback. Where there is no family physician, those complexes have struggled and have had problems with HPCSA accreditation. So it really is of value to put a family physician, because you want to actually encourage doctors to come and work in primary healthcare to strengthen the healthcare system, rather than to have them have an awful experience in their 6 months of exposure to family medicine and primary care, and make them actually not want to ever come back to that type of work environment. So thanks very much for giving me the opportunity.
Yeah, sorry for that. I just needed to attend. Committee Secretary and I were talking. Professor Richard Cook.
Chair, thank you very much. And just to add to my colleagues' very good comments, I just wanted to make the point that I think, with all humility, the Academy of Family Physicians acknowledges that there are many competing priorities that this committee indeed and many within the various provincial departments and National Department of Health are faced, particularly around the human resources matter. In this instance, though, it can be acknowledged that for the family physicians' involvement from a multidisciplinary team perspective within the district health context, indeed, the increased involvement of family physicians in both the planning and operationalizing of our health service renders those priorities, in fact, complementary as opposed to competing, if we were to be working together appropriately. I'm thinking of the context of mid-level healthcare workers in our district health services, of many of our different cadres within the multidisciplinary team who need to be working together under the clinical governance and leadership of our family physicians. Thank you, Chair.
Thank you very much. Let me thank all of you for your input. And also I did thank Prof. Russ before for the presentation. I think it's a great presentation that you have just done. It highlights and puts emphasis where it needs to be placed in terms of your writing to me, which unfortunately, as I said, it took a whole year for us to get to this point, but finally we got here and you've had your opportunity to make your points. I do hope that the provincial departments of health and the National Department of Health will note what has been put forward by yourselves. And of course, I also had received the same training, and I do understand the importance of the work. And I can hear that when you speak, there's passion in the work, there's passion for the work which you do in terms of delivery of services to patients. In the oversight visit that we had in the Eastern Cape, I emphasized that what health is about the service or the health outcome for the patient, for individual patients, group of patients, communities of patients, etc. It is not so much about having a room full of managers and then there's nobody who sees patients. There's nobody who takes care of the patient, whether the patient needs surgery and anesthetics for surgery, or just getting a clinical evaluation and a treatment regime put in place for that patient. That is what we are about as medical practitioners. And I'm quite excited that you've put this position paper and that you've had the opportunity to present it now. I'm going to allow the members to raise any points which they would want to. I had seen the hand of Honorable Dr. Thembekwayo. Any other members? Clark, Thembekwayo, Clark, Lamini, Wilson. Any other members? We'll start in that order for now. Kaba, and I will pick up the other members as we go along. So I'll start with Honorable Dr. Susan Tembakwayo.
Thank you, Chairperson, and thank you for the presentation that was done. I have only 3 questions to ask based on the issues for consideration. And the first one is there is a significant difference between provinces in the number of family physicians. Why is that, and how can they be more equitably distributed? The second one, what impact is immigration having on family practitioner numbers in South Africa? And the last one, how can more family practitioners be attracted to work in the public sector? Thank you, Chair.
Thank you, Honorable Clark.
Thank you, Chair. Yeah, there's some of my questions have now been covered by Dr. Tembakwayo, but just to add on to that is how much would it cost to increase registrar posts to 150? And what is the reason so few FPSs remain in the public health sector? Is it only the lack of posts that causes this? And then also just regarding the NHI, did the Academy give input or raise to their concerns regarding the bill and what was taken into consideration? And then I'd also like to know what recent innovations have been implemented in terms of dealing with resource constraints. That would be interesting to know. And then what universities are accredited in terms of accreditation for FPSs? Thank you.
Honorable Dlamini.
Thank you very much, Chair, and good morning to you and the other members. I also extend my greetings to the department people, but appreciating the presentation that has been done, Chair, I have just 2 points to make. The first one being the point of the rural people or rural areas, whether physicians would be prepared or are prepared to be assigned work in the rural areas, because I know in history of this country, there has been a difficulty of the shortage, not just of the physicians, but in general, some doctors would have chosen to be away from some rural hospitals in the districts or in the local areas. But I'm saying this because some conditions patients are facing would require them to be transferred to other institutions. So there will be a money factor in transferring somebody from a place to another place for a specific treatment, which is why I'm checking whether to avoid that, would we allow the physicians to be stationed in that particular area so that patients are receiving treatment they require, instead of being transferred to a hospital far away from where they stay. So that's the first issue. The second issue, which as the doctors were talking, I was also looking at the race, which made me to ask myself a question. Are there Africans in the leadership this category of the physicians. I'm sure we all agree that that is a very important question, because South Africa is made up of these races, and they have an interest, all of them, to have a South Africa that is receiving services in the equal manner. So for the family of physicians, do we have all races that are in South Africa in the leadership of the family of physicians in South Africa? Thank you very much, Chair.
Thank you, Chairperson, and to Prof. Russ, Prof. Andrew, Dr. Nash, Prof. Naidu, and Prof. Cook. Thank you for your presentation. I don't know if we should be saying congratulations or commiserations. You are all in an unenviable position. I think your presentation was superb, and I think anybody who's been working in the health sector long enough understands how very, very, very important family physicians are and the role that they play. Commiserations, though, because we can't employ you. It's quite simply that. And I want to go to that. So there's a couple of issues that I want to raise. And one of those is budgets. And I think this is where we are falling off the bus totally. I have a look at your 0.5 or 0.05s in positions in places like Limpopo. I'm from Limpopo. I go to the hospitals in Limpopo regularly. And the facilities are just not there. The infrastructure is just not there. The staffing is just not there. The nurses are just not there. The specialists are just not there. And there's certainly very few, if any, family physicians in these facilities. And when we look at the overall outlook of the budgets and what the provincial health departments have, most of them are running into accruals. Year on year, they have insufficient budget. The medico-legal claims, particularly in the more rural areas, are astronomically high. And I'm going to just say, you know, we have the Philadelphia Hospital in our area here, District Hospital. The medico-legal claims there are just astronomical. And that's got to come off a budget, and it's coming off predominantly the provincial health budget. So my question then goes to you. How do you think the NHI is going to change the situation? Do you believe that the NHI is going to improve the situation? And I'll tell you why I ask this, because first of all, it's going to take years before the most basic requirements on the NHI are rolled out. And that's going, you know, we've got to appoint boards beforehand for various things. They've got to make recommendations. That's going to take forever. They've got to have stakeholder engagements. That's going to take forever. So before the even most basic of the NHI requirements is rolled out, the situation's not going to change. You raised a very good point about prevention versus cure, and I what I'm seeing very much in South Africa is that we've become a curative health sector as opposed to a preventative health sector. And I agree with you 1,000%. Okay, when we are doing proper prevention, we save costs on the curative, and I really wish we could get that through harder. Because we've gone in the opposite direction. And that's making life very, very difficult. And it makes medicine more expensive. Absolutely it does. When you've got to go the curative route as opposed to the preventative route, you create a big problem in the health sector. And I wanted to, you had a slide there on primary healthcare services, okay, and the roles that family physicians play. And I think this is a big concern, and it's something we need to take into account. Where we engage with family physicians, doctors, specialists, and even nurses in the hospitals, the shortage of staffing is so huge that they are being overworked, sometimes to the point of collapse. And because of the role of a family physician, i.e., they're a consultant, they do the clinical care, they do the training, they become even more pressurized because they have to cover more roles than they're actually, I'm not going to say equipped, they are qualified to do it, but they're having to cover more roles than they should have because of staff shortages. And the end result of that is that they either quit, and particularly if they're in really, really rural, unequipped hospitals, and I'll use Philadelphia as an example, they end up leaving the system. And we're seeing more and more of this with the young interns and those people doing their first few years in medicine. It's enough to turn anybody to run to the hills. And this is, it's a huge problem. And then lastly, I just want to, 2 points I want to raise. One is the HPCSA. We get more and more and more calls from people trying to register or who are qualifying to register, but they're just not getting certified. Is this a problem for you? And can you give us some idea of how bad that has become? And then you talked about training programs in accredited facilities. Well, very few of our hospitals will meet standard at the moment, and we are under pressure trying to do that. When you talk of accredited facilities, are we talking about tertiary hospitals and universities, or are we talking about hospitals as well? General district hospitals as well. And I think that covers me, Chair. Thank you very much.
Thank you very much, Honorable Kaba.
No, thank you, Chair. Chair, I think let me join Honorable Stumo to welcome indeed the presentation, including Honorable Wilson, also welcoming the presentation, well presented, Chair, but also to raise the fact that, Chair, we are not at a space wherein the purpose of this meeting is to be discussing or unpacking challenges that NHI may be having. But I think what is positive is that the presentation seeks to introduce also and assist improvements in implementing the NHI to call for more clinical qualified professional doctors and other matters wherein questions of clarity had been raised. And Chair, having said that, I think out of being clarified and being brought to understanding, I will call that as the committee, we take note of the presentation and indeed we consider it also as an eye-opener, as our route is very clear on the NHI and going forward. This is an add-on in ensuring that quality healthcare and that is accessible to all is realized in South Africa. I thank you, Chair.
Thank you very much. There's a hand, Kefilware, which I'd not be able to take because this is a platform for members of parliament and those asked to come and present to them. I do not know the person named Kefilware. So I will now ask for any other members. If not, I think this is a wonderful opportunity, Professor Russ, for you to answer maybe a few questions, particularly with the emphasis of being able to explain to the community what your role is and what it is that you're asking for, because this is also being streamed by the Parliament YouTube streaming services, and so that you are reaching actually a large community out there and the public out there. So when we talk medicine, of course, we use a lot of terms and we use names and nomenclature, etc., which ordinary people wouldn't necessarily understand. For example, when you talk about family physician, medical officer, general practitioner, or you're talking about medical legal claims, you know, maybe say how you'd be able to assist as a family physicians in mitigating the medical legal claims, our risk and cost effectiveness, and also this thing that you're talking about of community oriented primary care and the role that you can play within that. Thirdly, why do you think is there a need to treat complex patients in the district? No, why not just refer them to a tertiary hospital and or to a regional hospital? And your throughput rates, which you were talking about, can you please maybe explain that at the various institutions? And finally, where do the family physicians go when they don't find posts within the state or the public health sector? Quite a number of issues raised by the members. We appreciate it, and I'm handing back to you. Thank you very much.
Thank you, Honourable Chair, and thank you, Honourable Members, for, I must say, a series of very insightful questions. I appreciate them. It's not often that we as academics are engaging at this level of insight with people outside of our discipline. So thank you for them. I'll attempt to answer them. Honourable Chair, just a question of procedure. Am I able to call on some of my colleagues to assist to answer some of the questions, or am I the one who...
No, okay. You are. You can ask any of them. Thank you.
Okay, thank you. And the reason I'm asking that, Honourable Chair, is because we work in different parts of the health system in terms of urban, rural, and different provinces. And I think it might be important to get a fairly representative response to some of these important questions. So I've just been looking at some of these questions and trying to clump them together, because I don't think we were able to go through them one by one, or should I do that one by one?
No, you can put them together. You can look at the trends on the questions.
Wonderful. Thank you. Thank you, Honourable Chair. So I want to start off with talking about just who this family physician is in relation to the other types of doctors that we find operating within the district health system. So what most people would know is who the general practitioner is. It's your private doctor who sits in his or her consulting rooms, and when you have the flu, or you have gastro, or you need to have someone look at your blood pressure, etc., you pop in and you visit your family GP. So typically the GP is someone who has fully qualified medical doctor registered as a independent medical practitioner on the HPCSA, but does not necessarily have any level of accredited postgraduate training. So they have the basic undergraduate training in place, but there's no standard at the moment for general practice in terms of the type of postgraduate training needed. So basically, any qualified doctor can become a general practitioner at the moment in South Africa. And typically they work in the private sector, billing either medical aids or out-of-pocket expenses to the patient. When we speak of medical officers, these are a similar cohort of doctors, qualified doctors, who are working within the state sector, largely within hospitals and clinics, who have also their undergraduate training, but who have not had any type of formal postgraduate training which feeds into the current work that they're doing. And so they might have very high levels of competence, both GPs and medical officers, but though that level of competence hasn't been objectively assessed, and so they don't have accreditation by the HPCSA to be on the specialist registry. And that sets family physicians apart from GPs and MOs, medical officers, in the sense that there's this accredited, standardized, objectively assessed training program over a period of time with a clearly defined curriculum, which then enhances the scope of practice of the family physician who has gone through this training. And that enhanced competence, which is externally assessed, is then accredited by the HPCSA specialist registry. So it may be that you're seeing the same type of patients, but on the one hand, you are mitigating clinical and medical legal risk by ensuring that the family physician seeing the patient is someone who has this fairly rigorous training and assessment and accreditation process behind them, and the expectation of leadership. That, I hope, answers the question of what is a GP versus what is a medical officer versus what is a family physician. Now, the impact on medical legal issues, on cost saving, on clinical outcomes, is largely mitigated by the quality of care that is delivered. So when we have good quality care being delivered within the context of a well-established doctor-patient relationship, where there are excellent levels of communication, if anything should go wrong, the evidence points to less medical legal risk if something does go wrong. And unfortunately, in the context of healthcare, things do go wrong for many reasons. And so when you have an accredited person who takes responsibility, who has been externally validated to be able to deliver a service, and this answers the honorable member's question about the quality of care in the rural areas. When you have that person situated in an outlying area, the quality of care, and when I say care, I mean comprehensively, the technical clinical services, in addition to the relationship management, is just enhanced so many times. And so the way in which we mitigate both on cost reduction and on medical legal risk reduction is via enhanced quality of care and a much higher level of risk awareness. What can go wrong and how can we prevent it before it goes wrong? So I think that for me becomes an important starting point. We first define who this person is, and then we understand how they are going to make an impact in our services. Now, I hear the multiple members talking about resources. And I would then argue that despite the fact that we recognize that at the moment budgets are constrained everywhere, one also needs to have a slightly longer term view. So while budgets are constrained currently, and admittedly one of the honorable members mentioned that part of that budgetary constraints is a response, is because of the high levels of medical legal cost. If one could then mitigate the amount of medical legal cost and drive down actual costs of service delivery because of a more rational use of resources, then the family physician offers an opportunity to save costs very significantly. Unfortunately, I'm not in a position to talk about numbers at the moment. I don't think we've had an economic assessment of what the family physician can do in this. And so that would be an interesting conversation to have. And maybe when I ask my colleagues to weigh in on some of the questions, maybe some of them have knowledge of that. But I think and as Prof. Naidu just mentioned earlier, it makes complete financial sense when we look at it from a systems perspective, that if we do a relatively small investment at the point of entry, which ensures that both medical, legally, and clinically we have a better outcome, then the costs upstream, the cost saving upstream in the secondary and tertiary hospitals and within medical legal claims justifies that expenditure at the point of entry. The question around the variable training programs, I'm going to lump the training all into one. So the process of accrediting a training program is that a university has to be, so it has to be from a registered university. At the moment, there are 9 universities in South Africa that are offering family medicine training programs, and we'll start north and move south. University of Limpopo has a growing family medicine department. Sefako Makgato University has a growing family medicine department. And I'll at the same time address the issue of transformation as a beautiful. I'll at the same time address the issue of transformation as I march through the different departments to give the honorable member a sense of where we are with transformation. Limpopo has a growing number of, let's call them Limpopoans, as part of the family medicine, the consultancy cohort. They've got some young indigenous African, South African family physicians who are part of the growing cohort. The same can be said for Sefako Makgato University. The same can be said for University of Pretoria, which is the next University on the list. And then Wits University as well. Growing cohort of indigenous African consultants coming through the ranks, remembering that as we traverse academic leadership, it's not something which someone can be rapidly transited into. Leadership within academia, as within any technical profession, needs to have a proven track record of achievement and contribution to the field. UKZN also has a growing number of indigenous African family physicians attached to their training complex. And then Walter Sisulu University is the next one. We also have University of the Free State, which includes not just Free State itself, but the Kimberley Hospital Complex, which services the Northern Cape population. And then in the Western Cape, the last two universities are Stellenbosch University and University of Cape Town. So I can say from a transformation perspective that each and every of the departments have a significant amount of emerging family physicians who have indigenous African ancestry, of whatever African ancestry Southern Africa offers. Our president currently of the College of Family Physicians of South Africa is an indigenous African. Our past president, indigenous African. And we have within the directorship of the South African Academy of Family Physicians, a number of people who have indigenous African ancestry. So I think there's an acute awareness, a very acute awareness within our academic community that we need to be representative of the broader South African population, not just from a perspective of seeming to be representative, but because the communities we serve must be served by people who understand the culture that those communities live in, but also the languages that those communities speak. I then want to talk about the actual training program and why the great variability in throughput rates. I think the great variability in throughput rates is intimately related to what the honorable member was speaking about, for example, in Limpopo, the budgetary constraints within the health sector. Remember that both the family physicians who are training our registrars and the registrars themselves are employees of the provincial departments of health, and they are expected to work within those facilities which are funded by the provincial departments of health. And these facilities are differently resourced across the different provinces. The differently resourced environments mean that the workloads are substantively different, in addition to the fact that the burden of disease in certain communities are substantively different. The workload has a direct impact on whether a registrar decides to stay in a program or whether they are able to cope with the academic demands. We've taken the decision as a national examining committee that we cannot, in the interest of public safety, we cannot drop the standards by which we assess these consultants. We have to ensure, once again, in the interest of patient safety, that once we've accredited someone to be able to operate at the level that we require them to, that they need to be able to show us competency at a particular level. And unfortunately, the learning environment in some contexts mitigates against this, and the registrar in those instances are at a disadvantage. What happens when the registrar graduates? And I'm going to touch on the HPCSA question, is that HPCSA the response has been variable. So in some instances, there's been a very rapid registration of the new specialists, and in some instances, a very frustrating, long drawn out process where people who are responding to the registrars, actually the biggest problem is not that the people responding don't understand the processes, it has been the level of response in some instances. I don't have a quantification in front of me to say this percentage versus that percentage at the moment. I'm just giving some anecdotal responses to that. So HPCSA has been variably very efficient and at other times not efficient. The one issue is that HPCSA is still using a paper-based registration process, which we've asked our executive to engage with about whether or not that can be made digital. But I don't think I can speak with much authority on HPCSA processes. So once the registrar is now registered as a consultant, that person starts applying for posts. And this is where the first hurdle is found. Oftentimes they end up working as junior doctors. There are posts for junior doctors, and these are people with families and with bonds and with commitments. And so they end up taking junior posts because they don't want to leave the area in which they live, where the kids are at school, where their spouse works, etc. And so most of our graduates stay in the country. In response to the question about are they leaving the country, most of our graduates stay in the country. However, that doesn't mean that all of them will enter into family physician posts. When those posts open up, we invariably have a significant large number of family physicians applying for those posts, which indicates that there's still a great desire for family physicians to work both in the rural and in urban contexts. I think we do recognize that there's a greater demand from family physicians to work in urban contexts, particularly in the larger metropoles. But even our rural hospitals, our far-flung hospitals, haven't really struggled that hard to fill the posts of family physicians. In a few minutes, I'm going to ask my colleague, Dr. Jenny Nash, to speak to some of the issues raised about practicing in the rural area, particularly around transferring patients and responding to the complexity of care at the rural, at the community level. But I just want to finish this thought about what then happens with these colleagues. So if they don't get a job as a junior doctor, or they don't get a job as a family medicine consultant, they either go into the private sector, which is why you saw that stacked in one of the slides, a fairly large number of people are working in private, or a small group of people actually leave the country. Now, the countries of interest that I've been made aware of is Australia and Canada and the UK, mostly Australia and Canada, because our training allows our registrars to work almost anywhere in the world. But that's not the majority of our graduates. My sense is that the majority of our graduates are staying in the country and they are willing to work in the state sector. And yes, they are willing to work in rural areas if those posts are opened up. Very Honourable Chair.
Dr. Nash. Sorry.
Yes, Dr. Nash, go ahead.
Thanks very much. So just to pick up on what Prof was saying, I work in the Eastern Cape, and as many of you know, we have challenges with infrastructure, as was mentioned by Honourable Member from Limpopo. And I think this is where we see the value of family physicians, because if you have a patient at a district hospital who, for example, has fractured their leg or needs a cesarean section, and you have to wait for an emergency medicine transport vehicle, EMS, that patient will develop complications. By the time the patient is referred to the next level of care, that procedure is far more difficult to perform. And so there's value in looking at what can be done at a district hospital. So there is a DHMO document for one of the NHI documents, which spells out some of the procedures that can be done at a district level. And this means that the patient is managed quicker. So let's use cesarean sections, for example. The baby has a better outcome. There's less blood loss. The mother has fewer complications. The mother's closer to her family. So the transport cost for her is much less. And there's also an opportunity for family members to come and visit her. And so that whole experience is a much better experience, as opposed to being sent off to a far distant site. Now, we know that many of our district hospitals are performing cesarean sections, but that's not the only sort of skill that can be done at a district hospital. There are many medical procedures that can be done. There are many surgical procedures that should actually be managed at a district hospital. And we know that as soon as the patient gets to a tertiary level, the cost increase for that procedure. And there have been some cost analyses where if you do, for example, an amputation at a district hospital and you do an amputation at a tertiary hospital, immediately that procedure is more expensive, just by virtue of the number of people who've been employed, the infrastructure, the theatre time, etc. So in the Eastern Cape, and maybe that just touches on one of the questions about innovations. In the Eastern Cape, we have identified, looking at workload and using the number of deliveries as a proxy for some of the workload indicators. And we've identified 28 hub hospitals, priority hospitals, where we feel should be doing providing a much larger basket of care, including surgical care. We know, you probably all know, that the Eastern Cape has a very high number of district hospitals, much higher than in other provinces, and this is as inheriting 3 health systems in administrations. And this is one of the innovations that we're trying to look at, in saying, let's not put family physicians at every district hospital in the beginning. Let's identify hub hospitals, which would be able to have a bigger complement of staff. If you're taking patients to theatre, for example, if you're needing to provide CPAP to support respiratory distress, then you obviously need slightly more staff. And let's make those hub hospitals having family physicians, or at least one family physician. And so the smaller district hospitals can refer to those sites. They're still closer to the community, they're still closer to families, and the services can also be the same expertise as you would find at a tertiary hospital. And we'd also like our tertiary hospitals to provide outreach to some of those district hospitals to upskill the patients, the healthcare workers. And so I think by looking at that kind of picture, it means that you are able to increase the number of patients who are being able to be assisted. So we have a huge number of patients needing a small number of tertiary beds. We've used one of the data collection tools, and I can tell you one of our district hospitals refers 1,500 orthopedic patients to Freya Hospital, which is our tertiary hospital that we refer to. Now, there's no ways that Freya can manage all of these patients, and that means patients lie in beds in district hospitals for literally months and weeks. But if we were able to do even 10%, manage 10% of those patients at a district hospital, we would increase the number of patients that could go to Freya and get services, and yet the number of patients would also be increased, number receiving the correct management. And if we could duplicate that across some of our high volume facilities across our province, that means that the overall standard of care would be improved, we'd have fewer complications, and obviously looking at litigations, maternal and orthopedic are very high on the litigation list. So I think there are creative ways of using family physicians in district hospitals to support clinical governance training, but also to improve access to some of the more, want to use the word, specialist services, working with our tertiary hospitals and regional hospitals, so that patients are able to get those services and overall support the district health system. I think I agree with the colleague or the honourable member who just said, NHI is coming in and family physicians are not going to fix NHI. But it's certainly one of the tools that we have to strengthen clinical governance. And we know that many junior doctors who work in district hospitals, if there's not some kind of leadership and support, they often become disillusioned. They don't stay up to date with new guidelines. And after a while, the standard of care it decreases. And that's where we have litigations and adverse events. And so by having family physicians who maintain their skills and keep up to date, they're able to help disseminate that information to some of the other members of the team. Thank you.
Thanks, Dr. Nash. I recognize Prof. Steinberg and then Prof. Naidu. And I wonder if in your responses, the things that we haven't touched on are very important issues and things that we deal with constantly. The one is, how do we pivot from curative to preventative services, given the staff shortages? And if possible, to speak to how do how do we adapt to working and innovating in a budget-constrained environment, and what are the potential implications for NHI? Yeah, Prof. Steinberg, I don't know if you were going to speak to that, but maybe between you and Prof. Naidu, if you felt you wanted to respond to those as well.
Thank you very much for the opportunity. I'd like to speak to the question of throughput first and then look at the funding. We have the Academy does track the throughput of registrars of the different programs. And as far as I remember, it is between 40% and 60% of those who start the program actually finish the program. Looking at the university where I am in the center of the country, we had over the eight-year period, we have a 60% throughput rate. 20% of the people left the program because of personal reasons. Children needed more care and time. Spouse moved away, personal reasons. And 20% left the program after we asked them to leave the program because they didn't make the academic milestones. So I do think that gives a good idea of throughput rates in our programs. Then I think the other issue is very clear. We started off the training in the academic complexes, but we need to move forward into the districts more and more. And there is a misunderstanding of who should fund the family physicians. Everybody would like family physicians, but nobody wants to pay for them. And I think that is something that needs to be sorted out. And clearly, 70% of the family physician core should be in the district. Thank you.
Thanks, Prof. Steinberg. Prof. Naidu?
Thanks, Taslim. So I think I'll try to address some of those. So the one question was, why don't refer complex patients to tertiary or to regional? So, it's easier said than done because those services are also severely hampered because of resource constraints. And often they would take really, really complicated patients. So the more complex patients actually get seen at lower levels of care because of the resource constraints. So when I last looked at the statistics, I think in the public sector, we have 0.25. Some provinces better, but in KZN, the number of doctors per 1,000 population is 0.25. Now the WHO recommends 1 doctor per 1,000 population. So even if you just put all the doctors together, the specialists and the medical officers, that's the figures we have. So that would tell you that we're all working under quite severe workload issues at the moment. A recent publication by Dr. Tim Carey in the SAMJ about why you need a doctor at each clinic is actually a very important publication because it actually shows the complexity of patients being managed by these doctors who service. It's actually an NHI appointed doctors who service patients in the Umgungun Lobo district. And what they've been able to do is manage these patients at lower levels of care and take the burden off the higher levels of care. Now, managing these patients and getting good quality of care is 2 different aspects. So when we talk about clinical governance, we talk about making sure that you are able to audit how you manage these patients and make recommendations for ongoing quality improvement. So that's where the family physician plays a really good, a really important role. The other question regarding curative versus preventative, I think as Prof. Cook has already mentioned, we should all see ourselves as functioning as part of a multidisciplinary team. So I think there is not enough emphasis placed on preventative care at all levels, even at primary health care, because even our clinical nurse practitioners are currently overwhelmed with the workload, multiple programs, lots of paperwork to fill in. So we should be looking at things like task shifting. And that's where I think it'll be really important to bring in, even community health workers to assist with some of those preventative strategies. So there's various good examples of how this has been done. There's this program called Group Empowerment and Training that has been used extensively in the Western Cape, where people are trained and they educate patients whilst they are waiting in the queues to see the doctor on understanding their medical conditions and managing them with lifestyle measures, etc. With regards to the budgetary constraints, I think what has happened in the past, and we've written from KZN through the South African Committee of Deans to the Portfolio Committee of Health, in terms of the severe budgetary restrictions in our registrar training, not only for family medicine, but for all the disciplines in KZN. And what has happened is that at family medicine, at one stage, we had 42 posts, and currently we're sitting on 9 posts, and it looks bleak in terms of the financial constraints. So maybe training of specialists generally should maybe be a national competency, and that national competency using both health professions training and development grant and tertiary services grant, and maybe some funding for public health and family medicine should come from district health services budgets, because ultimately you want to improve the quality of care at those levels of care. So maybe there should be an innovative way of reworking the budgets so that you address what the need in the country is, especially in the next 10 years. Another question that was asked about foreign doctors and the long process involved. So I think part of this may be due to HPCSA inefficiencies. But remember what happens if you graduate in a foreign country. The process is that the HPCSA has to get an external agency, and they use ECFMG, which is based in the US, to verify that the graduate has actually got the qualifications they say they have. So it's to prevent fraud and fraudulent doctors from practicing in the country. So once that happens, and that usually takes a while, the next stage is that these doctors need to be registered with the HPCSA, and before they do so, they need to write a qualifying exam, usually a written exam and a clinical exam. And it's usually the departments of family medicine that actually run these exams, usually twice a year. And once these doctors are once these doctors then pass this exam, they then have to wait in line for internship process. So I think all of this can take sometimes many years to happen. And the problem is compounded by the fact that there's inadequate funding. But the advantage of actually this process is that you are actually getting doctors who you haven't invested in their training. So they've trained elsewhere. And so it could actually help the service delivery shortages in terms of doctors. The problem obviously is that we don't know what quality of training we're getting, because the exam alone is not a good indicator of the competency of the doctors. Right, I think I've tried to address some of those issues. Thanks.
Thanks, Prof. Naidu. In the interest of fairness, I recognized earlier on that our colleague Dr. Kefiwe Hlabgayo had raised a hand at the inappropriate time, and I wonder, Kefiwe, would you want to make your contribution now?
Change. Thank you, Professor Ras. You know what I mean? Whatever I wanted to raise has been discussed. It's about the NHI, preventive medicine, and about the post. Thank you very much. I don't want to repeat. Thank you.
Thank you, Dr. Hlabgayo. Chair, before I hand back to you, I just want to deal with one final issue that you raised, and that is this issue of community-orientated primary care, which we as a family medicine community sees as one of probably the most exciting areas of expansion for the district health services, because it goes beyond the walls and the fences of our health facilities into communities, onto sports grounds, and into patients' homes. And I think when we think about money well spent and the pivoting towards preventative services, COPC is certainly a vehicle that we envisage to be a key strategic priority for driving the agenda of preventative services more and more in our communities. So I'm not going to go into the detail of COPC, just to put that on the table so that the honorable members and yourself can take note of it. Thank you very much, Chair, for this opportunity.
Thank you very much to all of you coming today to present your matter to the portfolio health. It's quite exciting for me to listen to all the clinical words being used. I would understand that it is also a learning tool. It's also a learning opportunity for all of the members of the portfolio committee, including myself. We appreciate you coming to speak openly and freely and telling us what the opportunities and the challenges are. I can clearly see the opportunities within the National Health Insurance for better health outcomes for the people of South Africa, should we get this deployment correct in terms of the services which could be rendered at the different levels of our institutions. And so I am quite mindful of what many of you had said in terms of the budgetary constraints, and the two suggestions made by Prof. Naidu, quite good suggestions about the training of specialists should be a national competency, and also maybe looking at the budget of the district health services and whether that would be able to assist with the training of registrars. This, of course, is not only a challenge with family physicians. We've had discussions with the South African Colleges of Medicine, and it's throughout. And there is a real problem with the intake of registrars at our training institutions. And I would think that we need to really, you should really have a discussion maybe with them and with the other specialists, and to see what else can be done to be able to improve the situation. 9 out of, I think it said, Prof. Naidu said 9 out of 54, if I'm correct, registrars intake, and that surely is a big problem. But it's 9 out of a large number. And the last time that I had a discussion with Professor Eric Book, we realized that there's a decrease of, if I'm correct, about 72% of intake, but it's a quite high number. We could get the correct number. You could even give me that correct number, but surely it is something that needs to be addressed. And there was a hand raised, but that's been lowered again subsequently, because as we're concluding, I can't remember whose hand was raised.
It was Prof. Andrew Ross.
All right, so that hand has been lowered then. Thank you very much again. I'm going to give you just an opportunity of 10 seconds, just make some closing remarks, and then we're going to end our meeting. Over to you, Professor Ross.
I just want to thank you, Honorable Chair, and the honorable members of the Portfolio Committee for allowing us this opportunity to engage with yourselves. Thank you very much.
You're very welcome. We appreciate you coming. Honorable members, that is almost the concluding. We are about to conclude. I only need to make 2 announcements. Our guests are welcome to leave the platform. Our guests are welcome to leave the platform now. But these are not private announcements. It's just that on the AIDS conference, we don't have authorization yet, but just as a reminder to yourselves that we've applied for attendance of the members of the Portfolio Committee to the AIDS conference. You have allocated the availability of yourselves, and we will communicate with you as soon as we have an indication of the approval for our attendance. The second one is on the study tour application. Unfortunately, again, our study tour application has been denied. And it is because of the program of Parliament at this point in time. And I had a discussion with the chair of chairs around this issue, who has then said that we could revise the dates for the study tour, and again, it doesn't mean that we would necessarily be afforded the opportunity to go and have the study tour. But we've repeatedly applied. We will continue to apply. Ms. Manchalamba and myself will have discussions on which other dates we could potentially look at. Unfortunately, for September, we do have some challenges because there are questions to the president and the deputy president, and also in October is the BRRR process. And so we would have to look at those dates again. Just for your notice, honorable members. Maybe one or two of you want to speak to those matters. And if not, we will close our meeting. Clock.
Thank you, Chairperson. I mean, I don't actually understand, because there'll be no better time than to do it during a period where we have a recess period, and build that work into our legislative work that is expected of us. Because I don't know about you guys, but we are expected to do legislative work and political work during this period of time. I mean, September, as you know, will be a tight program. And then October, we build up to a registration campaign. So, you know, I mean, in my view, there's no better time than, you know, from now until the end of August in order to build this as part of our legislation program. Thank you.
Anyone else? Honorable Wilson.
Thank you, Chair. Yeah, now I have a concern over this, in that every other portfolio is away. They've all been on study tours. There are people now on study tours, both in the NCOP and the National Assembly, and it's health that is being declined. Now, we can find every excuse, or the chair of chairs can find every excuse under the sun why we can't go. But they're preventing us doing what we're supposed to do and what we're entitled to do, and I have a problem with it.
You, Honorable Kaba.
No, thank you, Chair, for the update and announcement. I think we did receive notification with regard to the HIV/AIDS conference, and we have confirmed our availability. I think, Chair, we trust in your leadership and the administration. It has proved itself to be assisting us very well. And Chair, I think we really need to give you support, and we appreciate that you'll continue trying. For now, Chair, keep us abreast of what is available and within us. And I will urge all members to be supportive. I think we are a good portfolio committee, and we must progress very well in our work we do. Thank you, Chair.
Thank you very much. So, honorable members, Honorable Gela.
Thank you very much, Chairperson. Chair, we are noting the issue that you are raising, and really it's frustrating. We were told that let's deal with the bill and then will be considered. But we are with you, Chair. I join Honorable Clark and Wilson about the study tour issue, and also Honorable Kaba in their submission. We are supporting you, Chair. We are behind you. Maybe it will be considered again for us to go before this end of our 6th term parliament. Thank you, Chair.
Thank you very much. So, honorable members, yes, I appreciate you leaving that with the committee secretary and myself. We will make every endeavor to apply and reapply and to see what is a doable opportunity. And yeah, and then secondly, on the we'll also communicate on the AIDS conference, which is planned for I think the 20th to the 23rd of this month. There will be further communication on it. And then lastly, communication for next week's meetings, and any future meetings will also be made through the office of the committee secretary. With that having been said, I thank all of you for participation and have a good day. Don't forget about the plenary later today, and don't forget that we have a 3-line whip tomorrow, and all of your attendance is required at the 3-line whip. This meeting is therefore closed. Thank you.
Thank you, Chair.
Recording stopped.
Thank you, Chair.
Thank you, Chair.